Ladies and gentlemen, please find your seats. A warm welcome to the last plenary lecture for today. It's great to see so many people having survived the day during the conference. First of all, my name is Morten Grønbæk. I'm director of the National Institute of Public Health here in Denmark. I'm very honored to be the chairman of this plenary lecture for today. I would like to thank the organization for inviting me, and I very warmly thank Torben Jørgensen for having put together the program. I've been really looking forward to seeing these four presentations for today. The topic for today will be the advantage we have in the Danish, in the Norwegian, the Finnish, and the Swedish registers to make population-based register research, which is and we certainly do have quite a large number of advantages in this case, and we would like to do some sort of advertisement for this in all of Europe and most of the world, that we have these fantastic registers. What we will focus on today is the interrelationship between health and welfare. And we have four great capacities in the field representing each of the countries. We'll start out with Denmark, and we will ask Jørgen Olsen, who is a professor at the University of Aarhus, but also at the University of California at UCLA. And he will give us a talk in around 20 minutes on his experience with population-based research. Thank you, Jørgen.
Okay, thank you very much, Morten, and thank you very much for the invitation to come here today. What I'll mainly do is to go through a number of examples of use of these registers to illustrate what we can do, perhaps also to some extent what we cannot do with these registers, and then I'll also introduce this area with a few policy remarks and perhaps end up with a similar set of remarks. But first of all, that we have, as Morten Grønbæk mentioned, we have this opportunity to use registers that now have existed for decades in the Nordic countries in research. And we basically have 2 points of view concerning the ability to use these registers. So the first view is that, the positive view is that we are blessed with this abundance of population-based data on exposures and outcome and confounders in the studies, and these tool place us in a leading position to produce new and important scientific results. And more importantly, the value of these registers will only increase with time, and they will increase exponential with time. But the other point of view is that Nordic epidemiologists are doomed by all these registers that make them lazy and trap them into using poor instrumental variables for the real exposures and the real diseases. And they become prisoners of a national treasure rather than true scientists. They are also prisoners of upstream courses rather than downstream courses, which are now much more fashionable to study. And I think that both of these views are right to some extent. I do think that the first view is more right than the second view, is especially if you know when you can use these registers and when you cannot use these registers. And I'll try to illustrate a number of findings that have been made by using these registers, which actually would be incredibly difficult, or at least very expensive to produce if we had not had these registers. They are also important reasons for making collaboration across different countries, and many external researchers have come to the Nordic countries to make use of these valuable data sources. But of course, we also need other data, and we have to realize that that's definitely true. The advantage, the great advantage compared to ad hoc science, is that we have complete data, at least for some of the exposure and some of the diseases we're taking interest in. But more importantly is that we have this opportunity of having long-term follow-up. And long-term follow-up is really key now in modern public health. We know now that diseases develop over the entire life course, and you need to study diseases in several steps across this life course. That's not quite possible yet with most of the data we have available, but it will be available. We will have life course data over the next decades. Sometimes we do have high quality data, better data than we can get in ad hoc studies, and often we only have non-differential misclassification of these data and also of the confounders. But the important thing is that since these registers are covering the entire nation, and usually we can use these registers without asking permission, that's one of the critical issues that is being debated now. These registers are used by bending the European Directive on Data Protection perhaps to the limit, and everybody fears now that a new directive on data protection could change that completely. So what we have is, we have large samples, we have limited information per individuals, we have possibilities, however, to link this to research data. That's one of the options that has been used too little, but we can actually extend the data sources by linking that to existing population-based studies, and they are getting bigger and larger, as we all know. So national surveys or national cohort studies are being conducted. And again, that would also help in the ways to improve the situation with the lack of confounders and the lack of the possibilities of adjusting for confounding. We used to have actually very limited access to these registers. It's much better now, and it's mainly provided by a trusted third party, which could be, for example, the statistical departments in the Nordic countries that would host these registers and only provide access to decoded information to the researcher. We still have poor documentation of some of these registers. That's definitely something that we need to work on. It's better now, but it's not much better now than it used to be in the past. We used to have a lot of control of having access to these registers. That is definitely changed, and the decades of experience we now have without misuse of data has made that much better now. They used to be very expensive to get access to. That's much better now. What is really a main problem is that we cannot use the full potential of these registers that we have in all the Nordic countries. The Nordic countries have a similar public health structure, and it would be to some extent possible to use the combined set of data, making replication, making comparison, making much larger sample sizes possible for these studies. But this long-term follow-up is really the important issue, and it's an important issue because several of the diseases, from what we know now, develop over several hits over the life course. So we have these possibilities of using health data, occupational data, and they are all linkable, as those of you who come from the Nordic countries, through this personal ID number that was introduced in the 1960s in Denmark in 1968. Let me first provide you a number of results that illustrate things that can be done. There are many more examples that could be used, but this is a result. So the issue here is the public health problem and the clinical problem. If you get people who have taken, in this particular case, painkillers in an attempted suicide, what is their risk of actually committing suicide in the time period following that? You could do that by setting up a follow-up study, but it would be complicated, it would be difficult, because these are vulnerable people that have attempted a suicide and may not be very interested in taking part in research. But what you see here is that based on these complete follow-up of these data, we see an enormous increased risk in suicides following these events, clearly making this a key issue for clinicians to be aware of, that these attempted suicides are by no means harmless and should be carefully monitored. Another example is that we know that a lot of things are changing, including the age when people get children, and what is the optimal age of getting children. That depends upon a number of different issues, but one issue is actually what is the risk of having a fetal loss or spontaneous abortion as a function of age. And you see that this risk of fetal loss grows exponential with age, and one should be a little bit careful in postponing procreation too far. So that's also useful information to get out to the public. One of the key problems now is to look at the early phase of life. We know that many diseases start early in life, and Barker illustrated by using data sources from the UK with incomplete data and with substantial effort to follow these people over time, that birth weight is linked to the risk of cardiovascular diseases later in life. This is very easy to do in the Nordic countries. In this particular situation, we have been interested in looking at the risk of cancer as a function of birth weight, and it's quite interesting. We don't really understand why yet, but most cancers increase in incidence with an increasing birth weight, maybe quite simply as a function of larger organs and more cells that can be transformed into cancer cells. And it is also interest that this is not only for cancer, it's also for mortality in general. So one can, if one would look at the association between birth weight and mortality in general, we know that we have a high risk among those with a very low birth weight, but it's also of interest that these slides shows that we have a high risk among those with a high birth weight. So that's possible to do within a short period of time because data already exist. A lot of studies have taken an interest in nutrition during the time period of pregnancy, and Barker's hypotheses are related to a lack of nutrition that has programming effect and leads to insulin resistance. But another issue could be stress exposures during pregnancy, and there are good animal studies to indicate that stress exposures also have a programming effect that may have impact on the health of the offspring. So by using the registers, we have taken an interest in looking at people who have been severely exposed to stress during pregnancy. In this particular case, women who lost a child or lost a close relative while being pregnant, and then followed the disease occurrence among children. And one of the studies coming out of this indicate that this may be related to obesity, not obesity in early childhood, but only obesity that become manifest after the age of puberty, which fits with some of the theories behind this. So that's possible to do. It would be incredibly difficult to do. That's actually only possible to do in large-scale studies, and some of the studies relating this particular type of stress exposure diseases later in life we are trying to do now in a combination with data from Finland and Sweden and Denmark. Another issue is that we can sometimes respond very rapidly to problems that arise. Sometimes they arise because of poorly conducted studies. And here was a case control study linking vasectomies to cancer of the testis. And that was of serious concern for the WHO because using vasectomies as a family planning method was something that was advocated by the WHO. So if that had a risk of increasing the risk of cancer of the testis, that was a serious problem. Within a very short period of time, it was possible to collect information on all Danish males who have gone through vasectomies and follow them over time in these registers to see if they had an increased risk of cancer of the testis. And the results, and you see, are very reassuring. There are no increased risk of cancer of the testis among these men who had vasectomies in the past. So that was a suspicion that was clearly taken care of and had no major impact on the policy in family planning afterwards. This is a very recent example, just a few weeks ago. We know that use of mobile phones have been one of the most successful technologies. We have more than 6 billion users of mobile phones worldwide, and if they carry a risk, this would be a major public health problem. We know that they do carry a risk for people who use mobile phones while driving, but do they carry a risk for disease occurrence, that is less known. So the concern here has been about brain cancers, and as you probably know, a large-scale study coordinated by IARC in France called the Interphone study, using a 3-digit budget in millions, carried on this study on brain cancers and use of mobile phones. And one of the things they came up with was basically no association between use of mobile phones and brain cancer, except for the people who had the longest exposure, except for those who started using mobile phones when they became available on the market. And they actually became available on the market in the Nordic countries before any other countries. Unfortunately, some of the telecompanies in Denmark had stored their computerized data on mobile phone users, and that was used in the study. To skip the details of this study, but used in this study where they look at those who had a subscription, who had a record in these phone companies of using mobile phones from the beginning in 1982. And again, showing reassuring results, not being in line with the results from the case control studies, but showing that we have seen so far no association between use of mobile phones and brain cancers in any consistent way. And colleagues from Sweden also collected information on, just to illustrate that the normal monitoring that you can do when you have this data. So these are monitoring here based upon cancer data that have been collected for a long period of time between women and men. And here you had the introduction of handheld mobile phones in Sweden in 1987. And we can see basically no change in this pattern of incidence and mortality of brain cancers in this period. And if it would increase the risk of brain cancers by 40 to 60%, as the case control studies indicated, one would expect to see it in this monitoring system. One can do more detailed studies as well, doing family studies. Many exposures have different effects, not only genetic exposures, but also exposures belonging to the social group or the lifestyle factors, and therefore diseases may cluster over time. As illustrated here, if you look at women who had cancer of the breast at a young age, and you'll notice that they have an increased risk of a large number of cancers following that early event of a breast cancer, which may help in trying to elucidate the etiology, which probably will be mainly of genetic nature in this. So the studies makes it also possible to establish these family patterns and to somehow, in some cases, solve the nature and nurture controversies whether diseases are caused by external factors or by genetic factors. And one of the models that have been used is this particular model where that have been used in pregnancy research. So if you have, for example, a child with congenital malformations, then this family must have all the component causes available at that particular point in time, leading to this particular malformation. So if you look at women who had this malformation and look at the risk in the following pregnancy as a function of changing some of these patterns, you may get clues on what are possible causes of that, and you can do that in the same way by those who had a child without this particular congenital malformation. And that idea was used to illustrate that if you have a child with cleft lip and palate, for example, and if you change your partner from the first time, so if you had a child with a cleft lip and palate and change your partner when you're waiting, when you plan your next child, then you actually reduce this prevalence of cleft lip and palate from about 3 to 4% to less than 1%. Whereas in this particular study, there was no effect of changing the area where you live, and that can be expanded to a large extent with looking at other factors using this particular model. And this is another example using these family patterns trying to look at what is the risk of having a recurrence attack of coronary heart disease. So for people who have already had one attack of coronary heart disease, we know that they are at high risk of having a subsequent attack of coronary heart disease. And as you'll see here, that is a clear function of their family pattern. So if you have a twin brother that also has this history of coronary heart disease, that increases the risk substantially, and that declines with the less tight family relations later on. So to conclude from these examples, and many more examples could be used, we have a huge potential. What we need is much more open access, and I think especially open access not only to people from within the Nordic countries, but we would like actually to open these data sources to people from the entire world. And that's possible now with the computer technology that we have to do that in a secure way. We need much better documentations for these registers, and especially documentation in English if we are going to scale up the number of users, inviting people from outside. We need much better ways of correcting the errors that we have in these registers. As it is now, none of the errors, all of us who are doing research in these, using these registers, detect the errors, but they are never corrected. So the data owners are not really interested in correcting these errors. And we also need better methods to analyze this, and I think that is we're getting there now. There are more people who are interested in method development who also take an interest in this. So these Nordic registers have provided important public health information, and they could provide many other examples, but much more could be achieved if these registers could be combined. So if we use the Nordic registers in combination, then we can study rare exposures and rare outcomes. We can do replicate studies. We can look at differences in exposures and healthcare within the Nordic countries and see the consequences of that. And finally, just to end on this, this is being used by the permission we have from the European Union Directive on Data Protection by bending the rules to a large extent. In principle, you need to have informed consent in order to use sensitive data, and all health data are classified as sensitive data, unless there's a law saying that you can do this, for example, a law saying that you can have a cancer register, and if it is of value in public health. And some countries interpret that in a very strict way, that almost the future of the nation has to be at stake in order to open these data sources. But here in Nordic countries, they have said that most of these studies do have a public health interest, and they can be done in a safe way. And we all hope that the next directive on data protection will still allow this to be done. So thank you very much for it.
Thank you very much, Jørgen. Some very, very good examples for the effect on public health of these studies. Next speaker will be, unfortunately we won't have time to questions, sorry. But next speaker is Camilla Stoltenberg. Camilla is just appointed Deputy Director of the National Institute of Public Health in Oslo, Norway. Camilla is going to give us another few examples on the use of registers.
This one, I guess.
Yes, this one.
So thank you very much for inviting me to speak at this conference about the Nordic experiences using registries in research on health and welfare. And I would actually appreciate questions, so if anyone has questions, I'll try to leave time for it, and you can also interrupt me. Because I think that the experiences from the different Nordic countries are very similar to what Jørgen Olsen has already said, and there's not much to be added to that except for very elegant examples from all of the different Nordic countries. So I will give you a few examples, but then I will speak more about how we can modernize the registries and whether we should try to promote new ideas about how to manage them and use them and promote them outside of the Nordic countries. The theme of this panel was using individually linked population-based registers in research focusing on the interrelationship on health and welfare. So the 3 examples I've chosen, they are all using data outside of the field of medicine and health, in addition to health registries. And one example from using Norwegian compulsory national registries is a study of long-term medical and social consequences of preterm birth. And it was published in New England Journal of Medicine in 2008, not because the findings were very surprising, I think simply because we were able to follow close to 1 million children born at all different gestational ages and see how they were coping as adults. So this study did not look only at diagnosis, but that it was also looking at what proportions that were receiving disability pension, how many that were educated, how many that were employed, and could look at the whole range of outcomes, both in social terms and in medical terms. The study followed all children in Norway born between 1967 and 1983 up until 2003, and found that the risks of medical and social disabilities in adulthood increased steadily with decreasing gestational age at birth. So here the point is that it's possible to link not only the different health registries, but also the statistical or the data from Statistics Norway on social and demographic factors and on disability pension. Then the next study was published last year in British Medical Journal and investigated educational inequalities in mortality over 4 decades in Norway. It was a prospective study of middle-aged men and women followed for cause-specific mortality from 1960 to 2000. And this study found that there is an increased inequality. You can see that the red line gets steeper and steeper for each decade. So there has been an increase in social inequality and total mortality over these last 40 years, both for men and for women, although not as accentuated for women as it is for men. And then the question is, what causes of death are driving the increased educational inequalities in total mortality? And this was analyzed. I'm showing you only the table for women, but there's also one for men, but I think the one for women is more dramatic in many ways. It shows that cardiovascular diseases are accounting for a very high proportion of social inequality, but a decreasing proportion over the time period studied, while lung cancer and chronic lower respiratory tract diseases have increased immensely as a factor accounting for the inequality over the last 40 years. So that in the 1990s, those 2 groups of diagnosis together accounted for 26% of the inequality. So the mortality differences have increased over the last 40 years, and cardiovascular diseases still account for about 50% of the differences between education groups, and smoking-related differences play a significant role for these differences, accounting for 30 to 40% of inequalities in the 1990s, and smoking-related mortality plays a large role for the increased inequality from 1960 to 2000. The last example I've chosen is a bit more complicated to present, so I'll stick to the main point about the use of registers. It's actually a study by 2 economists in collaboration with a psychologist. And what they were studying was whether activation requirements during sick leave can control what they call the moral hazard problems in public sickness absence insurance and accelerate recovery. And they find that it can. So what they did was to study absentees who are issued graded or partial absence certificates by their physician, and they show that they have shorter absences and higher subsequent employment rates than they would have had on regular sick leave. It's a very complicated analysis, so I won't take you through it, but the point is that they used a whole range of data from different Norwegian administrative registers and had data on employers, employees, education, demography, social security, annual income and taxes, and also on they could identify physicians, not only patients. I mean, it was encrypted, but they could actually follow each physician and study their behavior and not only the patient's behaviors. And I think we will see many more studies of this kind looking at the healthcare system and behavior of healthcare workers in relation with the patients. And that's, at least in Norway, a newer way of using the data than what we have been used to in the more medically oriented epidemiological research environments. Then to the more general points. I think the strength of the Nordic health registries is that we can use them with population-based cohorts that have thicker and more in-depth data on the population, and that can be used both to validate what's in the registries, but also they can be embedded in the registries so that we can get the best of both approaches. And I think that combination makes or explains why there are many more large population-based cohorts in the Nordic countries, that the health registries actually, or the general registries, actually serve as an infrastructure for those cohorts. We can also use them together with biobanks, such as the newborn screening biobanks, or more specific biobanks collected in different kinds of research projects, both in population-based cohorts and in clinical research. So this is just trying to illustrate how the registries are sort of covering the whole society and many aspects of society, and then we embed these different approaches or infrastructures within them. And many European countries are trying to develop both biobanks and population cohorts, but I think it will be very difficult to succeed, and particularly to develop large ones that will actually give valid and reliable knowledge unless one develops a general structure of registries as a baseline for these cohorts and biobanks. So therefore I think that we should look for new ways of discussing how to use registries. Instead of just protecting the Nordic ones, we should communicate with other European countries and see how we can promote new views of development of registries so that they can be looked upon as safe and secure and necessary also in other countries. So I think I'll stop there. Thank you.
Thank you very much, Camilla, also for some very good examples and some very good points at the end. We may have one or two questions, but are there any? Yeah. You may want to go to the microphone. Anybody who has the...
Is the sound on here? Yes, because then I'll make one additional... Are you ready?
No. Any questions or comments?
Yeah.
There's one up here.
Hi, my name is Karen Blorham from the University of York in England. Thank you, both speakers actually, for fascinating presentations. I'm involved in a cohort study in one city in England. It's called Born in Bradford. And what we're trying to do is we have some bio data, cord blood, that kind of thing. We have an initial cohort. We have lots of embedded studies within the cohort, but we're also trying to link data of these children as they grow older, as they go through the healthcare system. So we can link quite easily with hospital admissions. We can link within Bradford with GP, primary care consultations, and we're developing links now as they get to school age with things like school data as well. So we're trying to develop this incrementally as we're going along, but on a much smaller scale. I just wondered if you had any particular lessons or things that we should look out for in this kind of small scale version of the fabulous work that you're doing in the Nordic countries.
Well, I know the Born in Bradford study, and I think it's an excellent study and that you're doing the right thing. But I think we should all look for international collaborations, and not only in the sense that we create common databases, but that we use the different cohorts together to look at, to have more variation. And particularly for smaller cohorts, I think that's absolutely necessary. But again, I think for all of us, it should be, or we should feel it as an obligation to try to explain that these things can be done securely, and that at least the registry data, that's data that's there already for other purposes, and there's not, or the authorities and people are not as scared of using registry data for economic purposes, for controlling the health services, etc. But they are scared of using it and create barriers against using it for research, which I think is very strange. And it must be possible to communicate that research is a safe and good way of using such data.
Yeah, Manfred Meyer from Vienna, Austria. I may be a very ignorant comment or question, but I'm still asking, could you tell us just very basic information about who collects the data, who cares for the data, and who has access to those registries, under which conditions?
Yeah. The healthcare system collects the data, and the data are stored, at least in Norway and Finland, Sweden and Denmark are quite similar, is stored in separate registries that are sort of outside of the healthcare system. It's organized in different ways, but at least in Norway, the Norwegian Institute of Public Health, where I work, runs 10 out of the 15 centralized national health registries. Those registries are organized in different ways, in the sense that 2 of them are encrypted in such a way that they cannot easily be linked with other registries. But it is possible. But they can't be linked with other registries that are encrypted. They're pseudonymous. And then there are registries that are have the personal identification number in them, but those registries have to be decided upon or approved in Parliament, each of them. So it's very difficult to establish a new registry of that kind. And the information that we have in a registry is very thin. There are only a few variables about each patient, but of course it's very comprehensive. But it is possible to link, so therefore you can add on. In principle, everyone who works in or is a researcher at PhD level or above and works in a sort of authorized research environment can apply to get the data. And if you have the necessary permissions, well, for getting anonymous data out of one single registry, you don't need any specific permissions. So you can actually get that just by applying and sort of explaining or documenting that you are a researcher. So those data you have the right to get within 30 days. If it's a linkage between centralized registries, it takes 60 or up to 60 days. So in principle, the data are quite readily available. But then the regulations are complex, so sometimes it does take much longer. It can take up to a year, for example, for very complex linkages. And in fact, I think that researchers outside of Norway can also apply freely, but it is very difficult to use the data without having someone who knows them work with you.
One last question. Oh, yeah. We'll have the mic now.
Yeah, Karl Frese, Luxembourg. Do you have a mode of incidental findings to communicate that back?
No.
So if in the research you find something which is of benefit for the patient? Okay.
No, but because all the research files are given out anonymously. And the amount of data in the all the data in the registry comes from patient records, so there's nothing new in them. I mean, you don't do additional analysis of biological samples and put it into a registry. You can do that in a research project, but not in a registry to be stored forever. So in that sense, you don't find those. You don't have those kinds of findings. And you have no way of reaching the individual patient. But each individual can access his or her own data, or has the right to see all their data in the registry whenever they want. Yep.
Thank you very much. And now it's time for Sweden. We will move to Sweden and ask Olle Lundberg to give us a short presentation. Olle is a professor in health equity studies and is now director at the CHES in Stockholm.
Is it on? No, it's on. Right. All right. Thank you very much for inviting me here and discuss this very important issue of registers and register-based research. I think this was supposed to be a Swedish view, and I also intended to be quite a personal view. Still, I think I will reiterate some of the main things that has already been said, so maybe we're not that different after all. But I wanted to, more in principle, rather than these wonderful examples, more in principle discuss the pros and cons of the use of population-based registers. So that's why the title is Advantages and Disadvantages. Maybe it's not disadvantages really, but rather problems that we encounter. But then again, let's take one step back and ask ourselves this link or interrelation between welfare and health, as it's said in the title for this plenary. What is then welfare? What does we mean with that? Well, we mean quite a lot more than just patients and treatment of patients. In Scandinavian welfare research, there has been a strong focus on resources, or more precisely, the resources by which individuals can control and consciously direct their conditions of life. If we follow the definition by Sten Johansson, who was one of the pioneers in the field in the 1970s. This means that what welfare researchers discuss in terms of resources is also very much the social determinants of health that you might have heard Michael Marmot talk about yesterday. So that means education, economic resources, working conditions, housing conditions, etc. And these resources are, of course, the ones that the individuals bring with themselves, their abilities, the resources that are created in the family or in the market. But there are also important resources that are supplied through welfare state institutions in terms of cash, that is sort of cash transfers through the social insurance systems that covers loss of income due to illness, unemployment, old age, or family policies. But there are also care resources, including healthcare, childcare, care for the old and disabled, and which constitutes free of charge or heavily subsidized services. And not only the individually raised resources are important, but the supply and quality of collective resources are important for people's possibilities to sustain their health and well-being. And I think this is where the Nordic wealth of registers kick in and becomes very useful for someone like me who likes to see if there are links between the welfare state setup and individual health and population health, and what these links might be, and if it makes a difference in the way which we organize our states. So these registers, they offer unique possibilities, I would say, for both monitoring and research regarding the links between welfare and health. And this is because they include a range of both exposures and outcomes, as have been already pointed out, including, as you know, demographic changes like births and deaths, etc., but also educational level, also income through taxation registers, also more of these services and income transfer programs on like sick leave, if people have been on sick leave, if people have been unemployed, and what times and durations of that, as well as hospital discharge records. So there is a wealth of registers being kept for sometimes or most often for administrative reasons, but that can be used for research. And of course, the key to all this, the key for the usefulness and the key for both research and monitoring on a larger scale, trying to link things, is the personal registration numbers. The unique numbers that makes it possible to link records in one register about unemployment, for example, with records from the population register on sex and age and family status, etc., with records on hospital discharges and eventually mortality. So through individual linkage, we can construct individual level research and monitoring data files that combine several single registers, and I think this is one of the main advantages. And these combined registers might then contain a range of important welfare resources and health outcomes. They can include, as have already been said, the whole population, which means that also small marginal groups can be studied, and very rare outcomes. They can cover long time periods, and they can link generations. And all of these features are, of course, very attractive and important. But as Camilla was discussing, I think personally that one of the major advantages of the registers in the Nordic countries are the possibilities to combine them with other data. The possibility to have interview data and link on content from these population registers. This, I would argue, enriches both the registers and the interview data. Typically, registers don't have very much content in the sense that we don't know much about how these people argue, how they have been choosing things. We don't know much about health problems other than those who have led to hospitals and led to mortality. We don't know details about working conditions or family conditions. All these kind of things we need to draw from other data sources, but we have the possibility to link on things. This means that we can have larger population studies and follow up mortality in a good way. We can have exposure of unemployment in a very good way. We can have one interview in 2000, and we can have unemployment spells during the following 10 years, and another interview in 2010, for example. And this also makes it possible to study effects of welfare state systems and what they are and how they work. Now, there are some problems, some that have been around for quite some time and some that have been emerging lately, I think. And these examples are mainly from personal experience and only from Sweden, but I think they may apply more generally. One is documentation. At least in Sweden and maybe also in Denmark, documentation of registers are not always well organized or always detailed enough. Very often it's the case that you need to track down single individual in the statistical offices or that knows a lot of things, when things have been changed, coding instructions, what certain variables contain, certain codings, what they mean, and you need to track them down. It's not found on paper. In Sweden, at least, most of documentation is in Swedish, which of course limits the availability of data for other people who don't read Swedish. There are a number of problems. There are small problems in Sweden, for example, with multiple use or reuse of personal identification numbers. We find two different people with the same number sometimes. But there are larger problems, for example, with migration flows. A number of immigrants in Sweden have zero income for the reason that they are no longer present in Sweden, but we really don't know. Finns go back to Finland and we don't know. It looks like they're still in Sweden because they didn't file a paper to the authorities saying, now I'm moving. So they're still in the registers. Family formation questions. With no formal marriages, we don't really know who are cohabiting and not, and there are difficulties in that sense, who are in the household and who are not. So there are these problems. But there are some emerging problems of accessibility that worries me, actually. Both Statistics Sweden, which is one major supplier of registers, and the National Board of Health and Welfare, who supplies health mortality statistics and hospital discharge statistics, have more and more pronounced projects, and they don't like databases. This means that the ideal situation for them to deliver data is one researcher with one project for one paper, and then you should sort of discard the data, and then you could apply for new data, maybe the same, but then for one other paper. This means that larger projects that have a larger research programs are not really allowed, and we're getting more and more difficulties to update our larger data sets, and it's really not what they like to do. So longitudinal, more complex, broader research issues are becoming more and more difficult in Sweden, right the opposite of what Jörn was asking for. There are also a number of restrictions on variable levels. We have had problems such as getting dates for hospital discharge. You can get a month but not a date, which of course severely limits our possibilities to analyze data. It can be hard to get country of origin. No, you cannot get the country, you could get the area of the world, which is of course also limiting to the extent of meaninglessness of looking at immigrants' health, for example. So, without giving any nice examples, because I think there have been many of those already, I think there are some reflections that could be made on the Nordic type or Swedish type of population-based registers. One is that these registers are very powerful tools for studies of welfare resources, welfare states, health outcomes, and other kinds of outcomes for that matter. Researchers should be using these possibilities more. And I also agree very much that I think there are a lot of things that could be done with Nordic comparisons. Policies that are different from Norway and Sweden, and we could use this difference to see whether a certain way of running labor market policies, for example, makes a difference in the end. So I think there are a lot of unused possibilities, there are a lot of studies still to be done. However, the use of these registers, it's not an easy task. It's not something you don't order a register and then start to deliver papers the next day. It takes a lot of know-how, time and money to get a knowledge and grip of the data. And that we can do. But then there have been this increasing difficulty with access, and I think that is a serious problem. If researchers don't get the access, it might actually be restricting the studies that we can do, and maybe researchers in the end go and do poorer case control studies, because that's something they can control themselves. So this is, I'm not as optimistic as Jörn seemed to be, but I hope that Camilla is right and that there are possibilities to go forward. Thank you.
Thank you very much, Olle. A little more depressing than the other ones, but very interesting to hear. We will have to immediately rush to Finland and ask Elina Hemminki from THL, the Finnish National Institute of Public Health and Welfare, to give the last talk.
And do you use that? Is that forward? This is forward. Okay. I can't see you, but I guess you can see me. The slide is disturbing. Registers have been a success story also in Finland. But the future has a number of question marks, and I think some of them have already been stated by the previous speakers. One of which has not been mentioned is the electronic patient records and the advances in IT technology. I have a feeling that when they are fully implemented in Finland and also elsewhere, the question of the status of registers may change, and they may be rethinking where do we put our resources. There's also this threat at the moment coming from EU in terms of privacy legislation and those issues. I will not go into that topic because I don't know too much of that, but I know that this is a nice issue. We did a survey some years back on the Finnish lay people's attitudes towards biobanks. And one of the interesting findings from that survey was that people were usually very positive of allowing their data being used if the users were Finns, if they were Finnish researchers or Finnish companies even. But if it was nothing to do with outside Finland, it was suspicious and people were not willing to give their data for such kind of use. So this is also something to think when we think about the use of registers in international research. I chose not to give examples because I thought if there are 3 presentations before me, there will be many, and I think there were many beautiful examples how valuable registers are for our understanding of health and health issues. I will give some technical things as I define them from Finland, and then introduce one new element which hasn't been discussed this far, the use of registers in experimental research. The first technical thing, the ID number, the identification number, I think it's a key, has been a key for success of the register-based research. This is an invented ID number, but what I want to illustrate that it's easy to remember. It's your birth date plus 4 numbers or letters. I think 99.9% of Finns can immediately give their person number when asked. So it's something you learn very early on, and it's used everywhere, outside of healthcare too. It has a correction formula so that if there is a problem, writing problem, one can find that there's a problem with the ID number. It's a unique, I don't think we have these double numbers. I've never heard about those, what you got in Sweden. It's a lifelong. You give it once and you have it forever. It's been used since 1964. Nowadays, it's given immediately after birth. There is no time lag. With number of registers, I won't go into that because of the time, but so there's a number of health registers in Finland. Many of them are held by the National Institute for Health and Welfare, from where I come, but not all of them, but most. But more important, there are other registers which can be linked to the health. Social welfare registers, there are also a number of them about pensions, social benefits, social assistance, all of these with the same ID number. Children taken into custody, institutionalized care at social institutions. So there's a number of those also outside the health care. Statistics Finland has something what I like to call a continuous census. It knows everything from everyone in terms of background characteristics, updated education, income, socioeconomic status, country of birth, language, when you get married, when you're divorced, emigration, immigrations, and also who are your children. Also the men who are their children. So it allows you to do family and generation studies. And more importantly, there are these exposure registers. There is no limit to them because I think there must be tens and hundreds of different kind of registers having the ID number in terms of work and others. I'll come to them later. Retki is the, I just want to give this address if someone is interested at looking at. It's the small unit in THL giving advice and support to the people who do register research. Most of the I think all of the examples we had actually, and I think most of the research which is being done with registers is observational research. But it can also, registers can also be used in individual-based trials to identify outcomes or to identify potential study subjects. What I think is maybe one of the interesting future trends in register-based research is to use them in what I call randomized healthcare or randomized interventions for clusters, in which you never see a person, you just get his or her data from registers, and the exposures are done collectively by healthcare or by other actors. I think this approach has much potential, even though little far used. And I have one example. No, I skipped this. This is a new, various names have been used for this randomized healthcare research. An example what I mean, this is one of the early ones I've seen. It's started in 1985. It's a breast cancer screening experiment trial, what they called program at that time. It was done by Matti Hakaman and his colleagues. So they allocated women by the year of birth to be screened or not to be screened, and all the outcome were collected from the registers. And all the work was done by the normal healthcare. This far, we have been talking about special registers, several of them. But in the future, when the electronic patient record will be more prevalent, I think we will face the question that do we still need these special registers, or should we think that we just have this enormous mass of electronic data, and then for each question, each research project, we will then retrieve the data from there. I personally think that from the researcher's point of view, the special registers are much, much better. They are technically, even though Olle said that they demand skill and experience and money, that's true, but compared to using the pooled electronic data, it's still technically easier, it's cheaper, it's more reliable and allows the researchers to concentrate on substance. But the drawback is that they have a limited predefined context. Question, is Finland, are Nordic countries special? I was, just before coming here, I was in USA for a couple of weeks doing research on regulation of research. But then I learned also other things unrelated to this question. And after that visit, I started thinking, are we really so special? I think 10 years ago we were special, but other countries have been catching up. Estonia, UK, particularly Scotland, Canada. There's a lot of registers, a lot of register-based research, and it's increasing. And even though they don't have this ID number, they have developed, well, Estonia I think has, but they don't have the ID number, but they have algorithms to identify the same person, not with 100% security, but still rather good matching. What is special, I think, in Finland and other Nordic countries is this ID number, which is unique and, as I said, lifelong, and it's used everywhere. And then the exposure databases. I don't think that the other countries have the same possibility to retrieve exposure from registers, partly due to the ID number, partly due to other things. I think there's endless sources, and I like this example Jörn had about these telephone companies. And I even heard that someone has got data how many minutes these people have been spoken to their mobile phones to get a dose response studies. And as mentioned, we also have data on consequences of ill health, which I think is also rather unique. And then these family connections, possibilities to combine parents and children and so on, so that I think is unique to Finland. And it's archived. It's there forever, I hope. Now, can I go on? Okay. I will end my talk with a slide which is very positive, but before that I will give some drawbacks, I think, which have not been mentioned this far. Well, kind of Olle took some of them up. Because the data is so limited in terms of health dimensions, some of the problem is that data determines research questions. We have to rely also on variables and definitions made by others. There is hardly any data, as far as I know, on self-rated health, opinions, experiences, or interaction with the healthcare givers. Much of the data comes of use of health services and not of the health itself. And getting data may be complicated. And it means that small-scale individual research, it's not possible. You have to have institutional backup and some money to do this research. But as said with all of us, I think the benefits are there, and I'm for register-based research, definitely. Thank you.
Thank you very much for the excellent talks by the four speakers. The speakers shouldn't leave before they received the gift from the organizing committee. Please don't leave before this. The rest of you may leave, and I look forward to meeting you at the restaurant in Øksnehallen. Thank you very much.